the kind invitation to the TSOC 2020. I'm honored to talk about cardiac acidosis, diagnosis, and management. And move to the next. My talk is on cardiac amyloidosis, evolving diagnosis and management, and you will find my disclosures right now on the next slide. I would like to introduce you to the diagnostic tools that are available for the diagnosis of cardiac amyloidosis in general, and then present some data on new treatments that arise. So as you all know, there are two different types of cardiac amyloidosis. We have to differentiate light chain amyloidosis and transthyretin amyloidosis, which are the most common forms of cardiac amyloidosis, and these forms account for over 95% of all types of cardiac amyloidosis, and then there are some rarer forms of cardiac amyloidosis shown on the bottom of the screen. And then we do have two different subtypes of ATTR-CM. On the one hand, it's the wild-type TTR amyloidosis. It's an age-related disease. Patients do not have any gene variant in the TTR gene, and predominantly male patients are affected by this disease. There are some specific clues or extracardiac signs that may include carpal tunnel syndrome, lumbar spinal stenosis, or biceps tendon rupture. And on the one hand, the second type of ATTR-CM is the mutant type. It's caused by a TTR gene variant, and there are more than 130 different mutations that are known to be associated with this disease. And patients present with symptoms of polyneuropathy or symptoms of cardiomyopathy, cardiac failure. So in general, the diagnosis of the disease starts with clinical suspicion. There are some clinical clues that raises suspicion of an underlying cardiac amyloidosis. So as I already mentioned, patients with carpal tunnel syndrome or lumbar spinal stenosis, there's a high amount of patients with these diseases having cardiac amyloidosis as well, mainly wild-type TTR amyloidosis. On the other hand, if a patient presents with macroglossia, it's a typical sign of light chain amyloidosis as well as periorbital bleeding. So you have to check or diagnose the patient to exclude or confirm cardiac amyloidosis or light chain amyloidosis in these patients. Then autonomic dysfunction can be a clue to diagnose amyloidosis in general, TTR amyloidosis, or a patient with diagnosis of hypertrophic cardiomyopathy who's older than 60 years of age could be a patient that presents with cardiac amyloidosis. So in general, there are some other typical diseases that are associated with cardiac amyloidosis. For example, the aortic stenosis in older patients. There's a high co-prevalence of aortic stenosis and wild-type TTR-CM. These patients, as I already mentioned, are older adults, mainly male patients with low flow, low gradient aortic stenosis. They do have higher blood biomarkers, for example, NT-proBNP, and a more severe diastolic dysfunction in comparison to patients with aortic stenosis alone without ATTR-CM. Moreover, in patients with HFpEF, with heart failure with preserved ejection fraction, a high prevalence of these patients presents with cardiac amyloidosis, as shown in this series from Spain. They evaluated patients with HFpEF by skeletal scintigraphy and found a prevalence of 13% of the patients presented with symptoms of heart failure and preserved ejection fraction presented to a hospital having cardiac amyloidosis as the underlying disease. These patients with positive scintigraphy presented with more marked increase of biomarkers, for example, NT-proBNP or troponin I in this series, as shown in this table here. And they do have a more severe hypertrophy with more marked hypertrophy of the septum, as well as the posterior wall by echocardiography. So these are potential indicators. HFpEF, heart failure with preserved ejection fraction, and aortic stenosis might be an indicator of, or you have to think about co-prevalence with ATTR-CM in these patients. So what is the way to diagnosis of the disease? So if a patient presents with heart failure, we already do ECG, echo, and MRI, as well as measurement of cardiac biomarkers. But we also have to look for non-cardiac signs or that are associated with ATTR-CM. So we have to do a neurological assessment, ophthalmological assessments, GI workup, renal diseases, and the family history. When doing echocardiography, a typical finding is the marked biventricular hypertrophy and the atrial dilation of the patients, as well as a thickening of the atrioventricular valves, as well as pericardial effusion. These are red flags of cardiac amyloidosis by echocardiography. And when using strain analysis, we usually find a normal strain in the apical segments and a very severe decrease of strain in the basal and midventricular segments. And this is called the typical apical sparing of strain, typical for cardiac amyloidosis. And strain may help to differentiate different forms of cardiac disease presenting with hypertrophy. So this is a very helpful diagnostic tool for these patients. Moreover, cardiac magnetic resonance imaging has become more and more available and has been used in patients with heart failure or hypertrophy. And this is very helpful because of the use of gadolinium, and there is a typical diffuse late enhancement in patients with cardiac amyloidosis, and especially a late enhancement in the atrial walls. And moreover, we are able to measure the extracellular volume, which is typically markedly increased in patients with cardiac amyloidosis. And so in general, cardiac magnetic resonance imaging is a very helpful tool for differential diagnosis of patients with left ventricular or with hypertrophy in general. for differential diagnosis of these patients. Moreover, the use of cardiac biomarkers is very important for risk stratification. In this series of Julian Gilmour from London, he presented risk stratification by the use of NT-proBNP and renal function, and he was able to differentiate the patients in 3 different cohorts with a high risk or low probability of survival in those patients with very high NT-proBNP above 3,000 and a low eGFR, and these patients do have a much shorter survival in comparison to patients with normal eGFR and low values of NT-proBNP. So if our initial evaluation increased the suspicion of an underlying cardiac amyloidosis, then we do have 2 different ways or options for further diagnosis. On the one hand, the invasive approach using biopsy, left ventricular and myocardial biopsy, followed by amyloid typing by either immunohistochemistry or mass spec analysis. And on the other hand, we are able to diagnose ATTR-CM non-invasively by the use of bone scintigraphy and after exclusion of a monoclonal gammopathy. And this has been incorporated in a diagnostic pathway, an algorithm that starts with clinical symptoms and including heart failure, syncope, bradyarrhythmia, and so on. And if there is a suspicion of cardiac amyloidosis, this diagnostic pathway includes bone scintigraphy. And if we do have a very high cardiac uptake of the tracer, which is graduated by the Perugini score, so if we have a high score, grade 2 or 3, and a negative screening for monoclonal gammopathy, then this pathway, according to this pathway, the diagnosis of cardiac ATTR amyloidosis is given, shown on the right side in the green boxes, and then we have to do a TTR genotyping to differentiate variant ATTR amyloidosis and wild-type TTR amyloidosis. On the other hand, if we not have any uptake or very low uptake and a positive screening for monoclonal gammopathy, then we should add or request cardiac magnetic resonance imaging to confirm cardiac amyloidosis or exclude cardiac amyloidosis. So the pathomechanism of TTR-CM is shown on the next slide. The TTR protein is consists of 4 monomers in the physiologically active form, and these monomers have a high rate of beta structure, and if this monomer dissociates into monomers, there is a high potential to build amyloid fibrils as the mechanism of the disease. And there is a small molecule that is capable to inhibit the TTR tetramer dissociation. This protein is tafamidis. It can be orally administered, and tafamidis binds to the thyroxine binding sites of the TTR tetramer and stabilizes the protein so that tafamidis inhibits the potential amyloid building step. And tafamidis has been assessed in a big phase 3 multi-center study. It's the ATTRACT study, and the ATTRACT study evaluated the efficacy and safety and tolerability of this drug in patients with ATTR-CM, either wild type or hereditary type of the disease. And the trial design is shown here. There are patients were randomized into 3 different groups. One group is the tafamidis group with 80 milligram. The second group is the tafamidis group 20 milligram and a placebo group, and the randomization was 2 to 1 to 2, and the patients were, the study duration was 30 months. Inclusion criteria are shown on the next slide. So patients were the age of 18 to 90 years. They do have documented ATTR-CM, either wild type or hereditary type, as already mentioned, and they should have a history of heart failure, with at least 1 hospitalization for heart failure. They should be able to walk at least 100 meters in the 6-minute walk test, and they should have a NT-proBNP of higher or equal to 600 picogram per milliliter. Patients with confirmed diagnosis of light chain amyloidosis were excluded, as well as patients previously treated with tafamidis, patients with a low eGFR below 25 milliliter, and if they do take treatments which includes non-steroidal anti-inflammatory drugs or other drugs given here, as well as patients in NYHA class 4 or after liver or heart transplant. These patients were excluded. Baseline demographic characters are shown in next table. So patients were at the age of 75 years, predominantly male patients, and approximately 25% of the patients who had mutant ATTR amyloidosis, and 3/4 to have wild-type TTR amyloidosis. Both groups, the tafamidis group and the placebo cohort, very well matched regarding clinical characteristics, echo parameters, the severity of heart failure according to the NYHA class, and cardiac biomarkers, NT-proBNP, troponin I. which are given here in this table. So let's have a look at the results. The primary endpoint was a combination of all-cause mortality and cardiovascular-related hospitalizations during the 13 months treatment study period. And as you can see here, there was a significant reduction of all-cause mortality and cardiovascular related hospitalizations in patients treated with tafamidis in comparison to the placebo cohort. And this results in a number needed to treat of 7.5 patients. When looking at the individual primary outcome parameters, the frequency of cardiovascular related hospitalizations, we also find a significant reduction, 32% reduction in the rate of cardiovascular related hospitalizations in patients treated with tafamidis in comparison to the placebo cohort. Similar results have been found for all-cause mortality. You will see a Kaplan-Meier curve for all-cause mortality for patients treated with tafamidis and in comparison to the placebo cohort. Patients treated with tafamidis, either 20 or 80 milligrams, are given in red. And there was a 30% reduction in the risk of all-cause mortality in patients treated with tafamidis in comparison to the placebo cohort. Let's have a look at some group analysis, which are shown here. There was no difference regarding the dose, regarding survival, and the frequency of cardiovascular-related hospitalizations. So no difference between the 20 and 80 milligram cohort, and no difference between wild type and mutant type patients regarding survival, and a lower frequency of cardiovascular related hospitalizations in patients with wild type ATTR amyloidosis. But we also see that patients with less severe heart failures, according to NYHA class 1 or 2, they do have a better survival if treated with tafamidis, and a lower rate of cardiovascular-related hospitalizations in comparison to patients with more severe heart failure, class 3, according to the NYHA class. So this gives first evidence that early treatment with tafamidis appears to be superior or better, and we should achieve early diagnosis of cardiac ATTR amyloidosis. Secondary endpoints have been the change of the distance in the 6-minute walk test and quality of life measurements. And what you can see, the next slide, is that there was a less decline of the 6-minute walk distance in patients treated with tafamidis, and a less decline of quality of life in these patients in comparison to the placebo cohort. And there was no difference in the change of the 6-minute walk test and quality of life measurements between the two different groups of 20 or 80 milligrams of tafamidis. So there have been additional analyses have been made looking at cardiac biomarkers and comparing the 20 and 80 milligram group that has been recently published by Thibaut Damy in the European Heart Failure Journal. And what was seen is that patients treated with the 80 milligram dose had a greater change of NT-proBNP if treated with 80 milligram in comparison to patients treated with 20 milligram. And similar results have been shown for the troponin I. So higher decrease of NT-proBNP in comparison to baseline after treatment with 80 milligram tafamidis in comparison to the treating with 20 milligram tafamidis, and similar results for the troponin I. And finally, looking at all-cause mortality, there was patients treated with 80 milligram in the long-term extension study. There was a significant improvement in all-cause mortality in patients treated with the higher dose. As you can see in this slide. So this was either unadjusted or adjusted to important markers, for example, age, NT-proBNP, 6-minute walk test result, and the combination of these parameters. Looking at safety, there was no difference between patients treated with tafamidis, so the pooled tafamidis group, in comparison to the placebo cohort. And there was a lower rate of discontinuation of treatment due to an adverse event in the 80 milligram cohort in comparison to the placebo cohort. So in general, treatment with tafamidis was very, very well tolerated in this study. So in conclusion, tafamidis significantly reduced all-cause mortality and cardiovascular-related hospitalizations compared with placebo, And tafamidis significantly reduced the decline in functional capacity as measured by the 6-minute walk test in the ATTRACT study, as well as the quality of life as measured by the KCCQ over S. And in general, tafamidis was very well tolerated and presented a very favorable safety profile. And this tafamidis is the only approved drug indicated for treatment of ATTR-CM in Germany right now. And as there is no treatment available that is capable to remove amyloid deposited in the tissue, it's very important to diagnose the patients as early as possible, and to very also important to initiate treatment as early as possible. Thank you very much for your attention.